Now we'll have Dr. Arsanjani come and speak with us about Beyond Echo, multimodality imaging of cardiac amyloid. Thanks.
Thank you so much for the invite. I don't have any disclosures. So it's going to pain me to kind of talk about as an echo guy why echo might not be the best option to look at this. So thick walls, not uncommon. Approximately 40% of people that we see in our echo labs have thick walls. And the major issue that arises with this is that how do you differentiate what is the etiology of the thick wall? So not all thick walls are the same. So on the left, you can have athlete's heart. You can have a hypertensive heart disease. You can have hypertrophic cardiomyopathy. We can have Fabry's disease, Friedreich's ataxia, AL amyloidosis. We can have TTR, aortic stenosis, as combo as Dr. Jamal just showed. And we talked about kind of differentiation between longitudinal strain. We talked about hypertensive heart disease. Generally, as you can see, with amyloid, we expect to have a lower global longitudinal systolic strain. So if we're looking at it, HCM has a little bit less. And again, depending on where the thick walls are, again, with this particular case, the strain is going to be lower. TTR amyloid, lower. Fabry's, and again, aortic stenosis and TTR. But you can see that, again, you potentially could have an apical sparing pattern. And we talk about this a lot. But what is the diagnostic accuracy of apical sparing and cardiac amyloidosis? So if you look at it in a kind of a systemic review of 37 studies, the sensitivity was 61% and the specificity of 83%. Again, and there's also vendor and software dependency. So again, although it's helpful, there's a large proportion of individuals that with cardiac amyloidosis that might not have apical sparing, and that doesn't exclude them as having cardiac amyloidosis. So again, has a good specificity. When we see it, it's helpful, but doesn't exclude the possibility. And then the idea with it is that this was another systemic review looking at a meta-analysis. Is longitudinal strain matter? And the answer is yes. Longitudinal strain has a higher sensitivity, but a lower specificity. And the idea with it is that the reason for that is that a lot of different disease entities can actually give you abnormal longitudinal strain, which I just showed. You can have this with hypertensive heart disease, aortic stenosis, amyloidosis. All of those potentially could have a similar pattern. Oh, sorry, go back. Okay, one more, sorry. So, can we go back one more slide? Okay, sorry about that. So when we look at this echo, we can see again, longitudinal strain shown on the right, kind of typical apical sparing. It's the 89-year-old past medical history of hypertension, hyperlipidemia, coronary disease, had a PCI 7 years ago, persistent atrial fibrillation, chronic kidney disease who presented with dyspnea on exertion. We did a PYP. Again, we did an HMDP, and this actually lit up significantly. So how does this work? And Dr. Jamal kind of went over this a little bit. Again, if we have somebody with increased wall thickness that we really can't explain, somebody with HFpEF, low flow, low gradient aortic stenosis, that should always kind of raise a flag for you. If you have apical sparing on your longitudinal strain, or if you have elevated BNP out of proportion to what you expect, think about it. And it's always important for us to kind of exclude AL amyloidosis. So we want to get monoclonal proteins, you want to get free light chains, you want to do the SPEP, UPEP. We often do get troponin and NT-proBNP level. If those are positive, they have monoclonal protein, you want to think about biopsy of an organ and then referral to hematology. If it's negative, we come down, we want to get a PYP. Again, if the PYP is positive, if it's negative, cardiac amyloidosis is unlikely. If it's positive, you think about cardiac amyloidosis, and then you want to do genetic testing for those patients. So what do we do? Again, there's no specific prep that's required. Generally, we think about PYP. Again, it's a 2 to 3 hour, although 1 hour is optional, although not recommended. In our lab, we have kind of, when we're looking at the interpretation, you want to kind of look at the visual interpretation, and we often talk about, again, if there's no uptake in the SPECT, that's important. A lot of people talk about heart to contralateral ratio. You want to look at the SPECT. You want to make sure there's actually uptake within the myocardium, because otherwise you might get fooled by blood pool. If there's no uptake in the myocardium, it's graded 0. How does the grading work? Again, if there's no uptake, and if you compare it to the rib is normal, that's grade 0. There's uptake that's less than the rib, that's grade 1. More uptake than grade 2, and significantly more than is grade 3. So again, heart to contralateral ratio is not necessary, assuming the monoclonal plasma dyscrasia has been ruled out. It does help in grade 1. So if you have somebody with a grade 1 and your ratio is abnormal, more than 1.3, you potentially could think about amyloidosis. A lot of times when we were just talking to Dr. Jamal before this session, we often talk about the really good sensitivity and specificity. If you have a grade 3, we talk about a specificity of 100%. And again, if you have grade 2 or grade 3, you can see again, if we just look at we didn't look at the SPECT, you potentially could have some false positive results as a result of it. Diagnosis, again, the ratio is not recommended in absence of myocardial uptake in the SPECT. If we look at the muscle and there's no tracer uptake, then that's likely blood pool, and that does not, even if whatever the ratio comes back in, that doesn't indicate it. If you have grade 2 or 3, it's confirmed. Again, the heart to contralateral ratio is not necessary. And again, it's typically concordant, and it's helpful in grade 1 for us to say, okay, if it's high and you have a grade 1, that potentially could help you to say, okay, this is potentially is positive or negative. In our lab, we actually use HMDP, which is another tracer. We actually do a 1-hour protocol, so it's a faster throughput. We did a comparison between 1 hour and 3 hour. No significant difference in diagnostic performance or the reader's confidence. So we actually do a 1-hour protocol and been successful at doing so. Unfortunately, as you guys are probably most aware, there's actually both a HMDP as well as a PYP shortage. So at the moment, that's kind of, we are having some difficulty getting the tracer. So what happens? What about false negative PYP scans? Can that happen? And the answer is yes. So this is a group out of, this is the French National Referral Center. So all of these patients actually had a biopsy. And if you look at it, out of 271 individuals where we actually had endomyocardial biopsy confirmed TTR, approximately 5% had negative PYP, meaning that you potentially, if the disease is early enough, you might not be able to actually pick up the disease on the PYP. And that's why it was important, if you have a high enough clinical suspicion, this came up this morning, that you should, if you have a high enough clinical suspicion, a biopsy should be considered in those individuals. And again, the idea with it is that, what about serial bone scans to assess response to therapy? Again, we put individuals on therapy. We really don't have a great way of monitoring who's a responder versus not. We're looking at some clinical parameters. We'll look at their biomarkers, but who actually responds or not? And is it worthwhile to us, once you actually have somebody on therapy, to repeat their bone scan? And the answer is generally no. Again, there's a poor correlation between the echo, biomarkers, CMR parameters, and what we pick up on the bone scan. In this particular study, what they looked at, in 42% of individuals who actually were having worsening symptoms, the PYP actually got better. So there's a discordance in regards to what the clinical parameters look like and when we pick up on imaging. So generally, repeating that study after it's positive to look at response is not recommended. MRI, again, it's probably, sorry, just one more click. So generally what we see, very similar to echo, we see thick walls, we see an enlarged left atrium. The EF generally is preserved initially. The image on the middle is our T1 mapping, and I'm going to go over the importance of that, and we can talk about the late gadolinium enhancement on the right and what that matters. So when we're looking at it, the MRI, it actually, what it does is it increases your kind of extra cellular volume. So because again, this is the amyloid is deposited there, you end up with this diffuse or transmural late gadolinium enhancement. And what it allows us to do, we can give you quantitative biomarkers. This is native T1, extracellular volume, late gadolinium burden, and these have been associated with disease burden, functional impairment, prognosis, and can be actually followed from response to therapy. Best test when we think about cardiac amyloidosis, but the echo is equivocal or non-specific. It can help support both TTR and AL. Generally with TTR, you have a higher amyloid burden, which comparatively, they have a higher extracellular volume and more extensive LGE, although there's some overlap. So you cannot just look at the image and say, oh, this person has AL versus TTR. And again, it allows us to get it significantly, allows individuals to be risk stratified accordingly. When we're looking at this, we talked about, again, you get increased wall thickness. We don't call it, is again, hypertrophy mimicker. So we always talk about in our lab, in the echo lab, we always comment on increased wall thickness rather than left ventricular hypertrophy, because it's not the actual myocardium that's hypertrophies with AL amyloidosis, it's the extracellular deposition that actually makes the walls look thick. As Dr. Jamal mentioned, you do end up with a smaller left ventricular cavity. You end up with biatrial enlargement. You do often have right ventricular involvement, and the right ventricle does appear to be thick, both on MRI and echo. You can have, again, both pericardial and pleural effusion, depending on the disease. And ejection fraction is often preserved till late in the disease. Late gadolinium enhancement, we often talk about this diffuse subendocardial, which I'm going to have some images. You can have transmural. Again, this is more common with TTR. We often have difficulty nulling. Nulling is when we actually try to make the myocardium appear as black on the MRI, and we have a hard time getting rid of the, making the myocardium appear to be black based on our sequences, and this has to do with the abnormal wash-in, wash-out kinetics with the cardiac amyloid deposition in the myocardium. And then with the T1, which I'm going to have some images, it will be elevated in both TTR and AL, and again, you can monitor it in individuals who you can give gadolinium if you're worried about renal dysfunction. So looking at the T1 mapping and extracellular volume, these are interrelated. And if you can get T1 mapping, if you have a hematocrit, you can actually calculate your extracellular volume is. When we're looking at this, again, from a cardiac standpoint, myocardial T1 is a relaxation time when we're looking at it from a pixel to pixel. And again, it allows us to get a quantitative map. Higher T1, we're thinking about amyloid, fibrosis, edema. And in lower T1, we're thinking about iron overload, which we're not going to be the focus of this conversation. So native T1, this is before we administer contrast, is elevated in both TTR and AL. Post-contrast, again, allows us to calculate your extracellular volume. And again, the idea with it is as you get more amyloid deposition, you get a higher extracellular volume. So ECV is going to be elevated in those individuals. Why does it matter? Again, the idea with it is that the native T1 rises because the amyloid expands the extracellular space. It allows us to look at the early detection. You can actually look at disease quantification, and you can monitor this potentially as a response to therapy. And when we look at this, again, you can look at it, it correlates with heart failure severity, your NT-proBNP level, your functional capacity. If you look at a 6-minute walk, the higher the ACV, the worse the individual's outcomes are potentially going to be. And again, it is a strong candidate for serial monitoring. And if you look at it from a prognostic standpoint, if your ECV increases, and in this particular study, the cutoff was 0.58, they have a significantly worse outcomes compared to people who had a normal ECV. So again, it does provide prognostic value for us. So key metrics, again, to follow when we're looking at individuals as a response to therapy, and this is a very hot topic. The idea with it is that if the person is responding to therapy, you expect that your extracellular volume is going to decrease, your native T1 is going to decrease and stabilize, and your LG often persists. Again, this is kind of a potentially slowly deteriorates. What response looks like in AL amyloidosis, ECV and T1 can decrease in responders. With TTR, with the silencers, you see ECV regression. With tafamidis, you often see slowed progression or stabilization with it. So if you're looking at this, and it does matter in regards to outcomes. So if you're looking at the individuals and you're monitoring them, the people whose extracellular volume and T1 got better, they actually, the survival is better. The ones stabilized do better. The ones that keep getting worse do worse. So meaning that if you respond to therapy and we can show that, those individuals do better. If we stabilize them, they do better. If they don't respond, obviously, that's not good. And again, if you're looking at the silencers and change into your NT-proBNP level, and these kind of all correlate, meaning that if you actually have somebody that responds, you would expect that the 6-minute walk is going to get better and the NT-proBNP level is going to improve as well. And then what do we expect from a tafamidis standpoint? Again, the idea with it is that the ECV and T1 mapping in this particular study didn't change significantly, but the idea with it is that when we look at the biventricular function, it got better, and your overall LV mass improved in individuals who were on stabilizers. So final, kind of coming to PET. Again, PET also allows quantitative molecular imaging. It potentially can pick up early detection before overt wall thickening, and I have some cases in our next talk of why PYP or bone tracers might not be the best tracers, because they often are late in the disease process, meaning the patient already has the disease before we do this, and it can actually allow us to look at the monitoring to therapy. Looking at it, the PET tracers that are available at the moment, again, there's 4 different tracers. Again, these can have either fluoride tracers or 11C tracers. They can actually look at the direct amyloid binding. And the strength is that, again, is they can actually quantify it. You can look at your, compared to the surrounding tissue, you can look at the uptake and look at the ratio, and allows us to look at the burden and response to therapy. The limitation is less standardized clinically than PYP. So evolizumab that we're actually looking at it as part of the done enrolling in the REVEAL study. It's a next generation PET tracer. It actually is highly specific for amyloid and can pick up both AL and TTR. What does that look like? So this is an individual, 63 years old, past medical history for dyslipidemia, had a history of prostate cancer. Prostate biopsy actually came back for amyloid that was not typed. Subsequently, fat pad biopsy and bone marrow confirmed that this individual has AL. Again, echo is shown, MRI is shown. Strain is shown, again, not normal, but not terrible. MRI, again, you kind of have this sorry, I don't know if I can actually make it work or not. You kind of have this kind of diffuse and almost like a transmural, but you have a lot of late gadolinium uptake. And this is what the PET looks like. You can actually see that the PET actually, the heart lights up on this tracer. So it is a binder. It actually has uptake in both TTR and amyloid. There might be some overlap between these. And the idea with it is that what does it add the most? It potentially is an earlier disease detection. And always, again, the conversation that we always have with we all kind of talk about if you wait till later in the disease and you start therapy, the patients don't do as well, right? So earlier therapy, the better the outcome. So if you have a tracer that allows us to pick up the disease earlier, initiate therapy earlier, potentially the patient does better earlier. And again, the beauty of it is you can actually quantify this and have follow-up long-term. Limitation, again, is not universally available. It's not the frontline nuclear test for ATTR. And the difficulty that comes up, and I know that other individuals this morning we were chatting about, is access, right? If you have a tracer that's very specialized and you're only going to have a few centers that are going to offer it, that might not be the best option long-term for kind of monitoring. Again, it's great when you have it, but if, I grew up in Oregon, if you're in Central Oregon, you're not going to get a PET. I just tell you that, again, you have to go to, another facility, and both my parents in their 80s, and they're not going to be very interested in driving 300 miles to get a PET if you're going to ask them. So just a couple of things to think about. So strength, we're talking about it. If you're looking at the PYP and SPECT, the PET is, again, it's widely available. It's highly specific for TTR, grade 2 and 3, and we're going to potentially talk about, again, picks up the disease later. Limitation is primarily TTR focused, so not an AL tracer. It's semi-quantitative. It doesn't help for follow-up. Strength of PET, again, it's a true quantification. It can detect both TTR and AL. And again, you can monitor for response to therapy, limitation, access, cost, and all the other things that we talk about. And when we talk about could you have discordant where your PYP is negative but your PET is positive, the answer is yes. You can get that obviously if you have AL, because again, TTR is not, AL is not going to be picked up. There's some overlap, but generally you have to exclude AL before you do your PYP. But if you have uptake on your PET, but your PYP is negative, think about AL amyloidosis. And you can also get this in early or variant TTR. And then a comparison, again, as I said, evenamutide tends to have better uptake and better discrimination for TTR, and similar to for AL, comparing to the fluorobutyravir, which has been available. This was already shown. For the sake of time, I'm not going to go over it. And again, so the idea was that cardiac MRI allows us to do tissue characterization and disease burden. Think about diffuse subendocardial uptake or transmural LGE. You have difficulty nulling, and you have increased native T1 and increased extracellular volume. It's strong for both prognosis and therapy. PYP, again, it's a frontline therapy, grade 2, 3. Think about TTR. That's assuming that there's no monoclonal protein. PET's coming. It's going to allow us to get amyloid burden and response to therapy. But again, think about CMR as burden prognosis, PYP as diagnosis, PET for quantification, and potentially therapy tracking. Thank you.
Great, thank you very much. Are there any questions from the audience?
I have a question about MRI. So I feel like a lot of the cases that we have trouble with or misdiagnoses begin with an MRI. But if you can kind of explain why do you seem to be seeing that, right?
Sorry, so MRI, you mean in regards to ATTR versus AL, or just in general? So when we're looking at the MRI, you can have late gadolinium enhancement for other reasons, right? So the idea with it is that you have to put the entire clinical picture together. If you have somebody that comes in, they can have a transmural infarct because they had a prior myocarditis, right? Doesn't mean that you have to have AL. And if you have abnormal T1, it potentially can indicate, again, if you have fibrosis for other reasons. There could be overlaps between these. You potentially could have somebody with Fabry's that can have a similar MRI than to somebody who potentially has false negative on the MRI. If you have disease, it will be highly unlikely. I don't know. What do you think?
What do you think about the expertise in the community?
Could you have a false negative from a misdiagnosed? I mean, you generally, if you have amyloid deposition, your T1 is going to be abnormal. We do know that, again, the higher the disease. I would have a hard time saying that it would be I don't think that I've had a case where MRI was negative that we then subsequently diagnosed it. I have patients who had a normal PYP who then had an abnormal MRI, who didn't have monoclonal antibodies and was early in the disease. I've had that, but I haven't, not the other way around.
Well, can you trust community cardiac MRI?
Can you trust, I mean, trust but verify, right? Always.
So great presentation. I have a question on the value or the results of PYP in AL amyloidosis. How often is the PYP positive? And second associated question, if it is positive, is it usually grade 2 or 3, or if you have a grade 3, is it less likely to be AL?
The answer is that, so when they looked at the studies, there's definitely some overlap. If you look at the heart to contralateral ratio, if you use a cutoff of 1.3 as your cutoff, right? There's definitely some individuals with AL that have it. But the reason we always recommend getting the monoclonal evaluation, because AL is it's a hematologic emergencies, and so you want to catch that early. TTR, and I have a case which I'm going to show of somebody that we followed in clinic for 5 years before the diagnosis was made. But with TTR, you have more time. With AL, you don't. But there's definitely overlap. Generally with grade 3, and I'm not advocating for this. You always have to get the monoclonal protein, but it would almost be always TTR.
Okay, that's what I suspected. Thank you.
Of course.
Are there other questions? Well, great. Thank you both.
Absolutely.